So, should we start the meeting?
Yeah, I think so.
Okay.
Hi,
Hi, good.
Paul.
Hello, Professor.
How are you?
Hello, konnichiwa.
Konbanwa.
Salam alaikum.
Waalaikumsalam.
Abida has just joined.
Okay. Because of the time has already passed 2 minutes from the time it should be to start. I would like to start this event of ACNS Women in Neurosurgery Young Neurosurgeon Meeting Webinar. And our speaker would be Professor Takeo Goto. And then the second speaker would be Dr. Sneha and also Dr. Moyokota from Japan. And the first speaker would be Professor Takeo Goto from Osaka. He's one of the best in the world of skull-based neurosurgeon. Please, your presentation would be the first to present. Please, Professor.
Okay. Thank you for kind introduction. I feel very honored to have opportunity to present my work in front of many young neurosurgeons in the world. At first, I would like to share my screen. So, can you see my slide?
Yes.
Okay. So now I will start the endoscopic keyhole approach to skull-based tumors. As already we know that recently endoscope was well developed, and endoscope can offer the panoramic wide and clear view around the deep CT area. But it's even now it's not clear which disease can be safely resected by the endoscopic keyhole approach. So today I will present our endoscopic keyhole approach and the indication of this approach. Before start the endoscopic keyhole approach, I at first explain our very important principle how to resect the skull-based tumor by the microscopic or endoscopic approach. This is a simple illustration. Skull-based tumor can arise somewhere in the skull base, and after increase the size, tumor compress the cranial nerve and vessel and cause some symptom. At that time, we have to resect the tumor. But at that time, it's not good to access the lateral margin of the tumor and not pull out the tumor outside. If we just pull out the tumor outside, in all procedure, we have to increase the tension to the cranial nerve. So even carefully resect the tumor, we have some risk to damage the cranial nerve or vessels. So our strategy is very simple. In all cases, at first access to the origin of the tumor and perform the partial dissection, internal decompression of tumor, and carefully pull the tumor back to the center of the tumor. After this procedure, in all cases, the tension of the cranial nerve and vessel relieved, so we can find out the dissectable arachnoid plane. And then we repeat the same procedure. We gently dissect the tumor and pull the tumor to the center of the origin to the tumor. So finally, we can resect the tumor. So when we resect the skull-based tumor by the microscope or endoscope, anyway, we have to keep this principle, access to the origin of the tumor at the initial stage of the surgery, and then gently pull it back, the tumor, to the center. If this procedure can be achieved by the endoscope, in such situation, endoscopic keyhole approach very useful minimum procedure to resect the skull-based tumors. I will show the several cases step by step. At first, I will show our endoscopic keyhole subfrontal approach. Usually, I put the incision eyebrow and make the craniotomy with a size about 3 centimeters. And then I insert the endoscope to the frontal base. Brain retraction usually very minimum, but endoscope can offer very good panoramic view around the frontal base or 𝙀𝒌𝙚𝒂𝙠𝒂. So we can observe the both optic canal and also can open the both optic canal. So this is a tuberculum meningioma. This tumor can be safely reject this tumor based on our principle. So I use this approach. At first, the size of craniotomy is usually 3 centimeters, and then I carefully insert the endoscope at the frontal base. Now, at the initial stage of the surgery, we could reach the attachment of the tumor. I gently drill out the tuberculum cellar and also carefully open the optic canal under the endoscope. Then I cut the dura to relieve the optic nerve. At the initial stage of the surgery, optic nerve already decompressed. So I start the tumor removal. At once, anyway, I completely try to detachment of the tumor and then carefully remove the tumor piece by piece. I open the contralateral optic canal and repeatedly perform the internal decompression. So finally, all tumor was rejected out. So we needed the special dissection technique, but the access to the region is correct. So we can safely reject it out all tumor. Post-operatively, all tumor was nicely rejected and her vision improved. If the tumor is the frontal base olfactory groove meningioma, our strategy is the same. We just put the eyebrow incision and put the craniotomy with a size about 3 centimeters. But using the keyhole endoscopic approach, we can directly access the attachment of the tumor. I mean, at the initial stage of the surgery, we can completely devascularize and detach the tumor. So tumor removal was not so difficult. So through the small keyhole, but the tumor was nicely rejected out. So if we try to reject the tumor around the tuberculum cellar or frontal base, endoscopic keyhole approach was very useful because this procedure completely follow our basic rule. We published this technique to World Neurosurgery. So if you have some interest to our procedure, please check this paper. Then I will present our endoscopic keyhole anterior transpetrosal approach. I usually put the incision around this area and then put the craniotomy with a size of also 3.5 centimeters, and then insert the endoscope around the frontal temporal base. Endoscope also can offer very clear and wide view around the petrous apex. So after drill out the Kawashi's triangle and open the Meckel cave, we can expose the trigeminal nerve from the Meckel cave to brainstem. So if the tumor attached around petrous apex or petroclival junction, we can directly access attachment of the tumor through this keyhole approach. So this is a petrous apex meningioma causing the trigeminal neuralgia after the gamma knife. So I use less invasive treatment to completely detach the attachment of the tumor. At first, I put the craniotomy with a size of 3.5 centimeter, and then gently insert the endoscope to temporal base. I at first identify the GSPN using the facial stimulator, and then expose the anterior petrous bone, I mean 𝙀𝒌𝙠𝒐 triangle. I drill out the anterior petrous bone carefully, and then cut the dura mater. This is the attachment of the tumor. So at the initial stage of the surgery, I coagulate and detach the tumor. So now we don't encounter the bleeding, so we can carefully dissect the tumor from the fourth nerve or inferior surface of tentorium. So now we safely resected out all tumor. This case, a tumor compressor SCA, and SCA compressor trigeminal nerve. So I mobilize the SCA of the trigeminal nerve, like this. To achieve this procedure, endoscopic keyhole approach was enough. And then we insert the endoscope to deep sheet area. We observe the 6th nerve and 7th and 8th nerve. This surgical will be very similar of that of microscopic anterior transpetrosal approach. So this is a post-CT scan. Very limited anterior petrous bone was drilled out, and tumor was nicely resected out. This is another case of the trigeminal schwannoma, occupies the Meckel cave, posterior fossa, and infratemporal fossa. But using our endoscopic keyhole approach, we can directly access the Meckel cave, posterior fossa, and infratemporal fossa. So we can resect out the tumor based on our rule. So I use the same procedure. The size of craniotomy also same, and the procedure also same. At first, I identify the GSPN and expose the 𝙀𝒌𝙠𝒐 triangle, and then drill out the petrous bone, and then open the Meckel cave. Now we expose the tumor. In case of the trigeminal schwannoma, just subcapsular dissection was enough. No need the special dissection. So I repeated the same procedure, internal decompression and subcapsular dissection. Finally, we could resect it out all tumor. Tumor in the Meckel cave, posterior fossa, and infratemporal fossa was nicely resected out based on our rule. This is a relatively large trigeminal schwannoma, but concept is the same. If we choose the endoscopic keyhole approach, we can directly access the origin of tumor and carefully perform the subcapsular dissection, so all tumor can be resected out. This is another case of the recurrent chondrosarcoma, but the patient has osteogenesis imperfect. So this angle was very steep. But if I use the endoscope, we can see the superior margin of the tumor and also can reach the origin of tumor. So I apply the endoscopic keyhole approach. This is a tumor, and this is a fourth nerve, and this is a trigeminal nerve. We can access the origin of tumor, so we can perform the careful dissection of the tumor. This is trigeminal nerve, so I resect the tumor step by step, and then decompress the tumor from the brainstem. Finally, almost all part of the tumor was resected out without any deterioration of symptom. This is another case of the relatively small petroclival meningioma. we follow this patient, but the size of tumor increased very quickly. So we decided the tumor removal, but the patient age was very old. So I choose the same procedure to access a petroclival junction. The size of craniotomy is the same, and the procedure also same. I open the Meckel cave and drill out the Káwase's triangle very carefully, and then cut the tentorium. So, through this approach, at the initial stage of the surgery, we can detach the tumor. I mean, we could access the origin of tumor. So, we can safely resect out the tumor. This is a fourth nerve, and this is a SCA, and this is a medial side of the trigeminal nerve. So, it's the attachment of the tumor. I carefully coagulate the attachment of the tumor and repeat the decompression and detach the tumor step by step. Some part was very calcified, but recently we have the good quality QSA, so we could crush the very fibrous tumor, so we could safely resect out this fibrous part, and the brainstem decompressed like this. This case also compressed the third nerve, but already most part of the tumor decompressed. So tension to the third nerve relieved. So we can resect it out from the third nerve. Finally, most part of the tumor was resected out. This is a post-op MRI. Most part of the tumor nicely resected out. This is another case of the petrous apex meningioma, but nicely resected out through our keyhole approach. And this is the same. The tumor was not large, but attachment was wide. The tumor has attachment along the sphenoid ridge and lateral wall of cavernous sinus and petrous ridge. But if we use the keyhole approach, we can observe the attachment of the tumor at the initial stage of the surgery. In such situation, we could resect the tumor by the keyhole approach. I carefully open the Meckel cave and remove the tumor piece by piece. This is a trigeminal nerve in the Meckel cave, and this is a tumor around the posterior fossa. I carefully resected out the tumor, and we expose a brainstem. I carefully resect the tumor piece by piece, like this. And then this is the lateral wall of cavernous sinus. I peel off the tumor from the lateral wall of cavernous sinus and remove the tumor. Finally, most part of the tumor successfully resected out without any deterioration of symptoms through the keyhole. So we recently published this technique also to JNS. So if you have some interest, please check this paper. Finally, I would like to introduce our keyhole interhemispheric approach. This approach was also very useful to the if the region attached to the falx. This is a falx meningioma located in the middle third. But if we access this attachment of the tumor from the contralateral side, we can directly access the origin of tumor. So we could resect it out this type of the tumor by the keyhole endoscopic approach. After insert the tumor, we can directly observe the attachment of the tumor from the contralateral side. We place the patient to lateral position like this. So this is a left occipital lobe, and this is the right side. So now interhemispheric space was well exposed by the endoscope. And the tumor already detached, devascularized. So we can smoothly resect it out through the keyhole, and then tumor was nicely resected out. This is another case of the midbrain cavernoma located the dorsal side of midbrain. In such situation, keyhole occipital transtentorial approach was very useful. I place a patient left side down, the park bench position. So this is a storage sinus. I cut the tentorium, and this is a deep venous system. Endoscope can offer very wide and clear view under the deep venous system. So we can follow the margin of the cavernoma. So I carefully resected out the tumor. Finally, this is a abnormal vein. We can preserve this vein, and then tumor was resected out. The tumor was successfully resected out without any deterioration of symptoms. This is the tentorial meningioma, but the concept is the same. If we use this approach, we can detach the 𝑦𝒅𝒄 and tentorium at the early stage of the surgery. So we apply this technique to such kind of the tumor. We place a patient to lateral position, and this is a petroclival junction, 𝑦𝒄-tentorial junction, and this is a tentorium. We carefully cut the 𝑦𝒄 and the tentorium and continuously perform the internal decompression. Finally, all tumor was resected. If the size of tumor was large, but concept is the same. If we apply this technique, we can directly observe the 𝑦𝒄 and 𝑦𝒄-tentorial junction and can remove the tumor. We place the patient to lateral position, and the procedure also same. At the initial stage of the surgery, we can detach and cut the 𝑦𝒄 and tentorium. So when we resect the tumor, we cannot encounter the large bleeding and tension to the neural tissue relief. So it's easy to identify this border. So all tumor was nicely resected out and also preserved this venous system. So also we published this key for the interhemispheric approach. So if you have the interest, please check this paper. So today, I present the three endoscopic keyhole approach: subfrontal, subtemporal anterior transpetrosal, and interhemispheric approach. In all approach, we can just follow the basic rule: access to the origin of tumor, and meticulously pull the tumor to the center of the tumor. So we can safely resect out the tumor through the endoscopic keyhole approach. In addition, in case of the endoscopic surgery, we cannot see the proximal side of endoscope. But in these three approach, proximal side of endoscope was very safe. We can make the very safe surgical corridor around this area, or this area. So we can apply this technique to skull-base tumor. Of course, there is some technical tip, but endoscopic keyhole approach can be very effective procedure for removing various kinds of skull-base tumor. Thank you for attention.
Thank you very much, Professor Takeo Goto. It's very beautiful, wonderful removal of tumor and wonderful technique. Before I continue, I would like to thank you for my opportunity as chair here to Professor Raja and Professor Yu Bunseng, especially to our president of ACNS, our Honorable Professor Yoko Kato from Fujita Bantane. And I would like to introduce you the moderator of this ACNS Women in Neurosurgery webinar, the chair of ACNS Women in Neurosurgery, Dr. Saran Theophilus from Johor Bahru, Malaysia, and then Professor Abida Shah from Mumbai. She's our moderator right now. And before going to the next speaker, the discussion will be led by our moderator. Please, Dr. Saran and Professor Abida.
Okay, thank you very much, Mirna. Actually, I think it's okay if you just continue. We will just if we have anything we can add on. Yeah, since you are our honored guest today for the to run this whole webinar, and we are honored to have you here today and together with our discussants. All right, so I think you can continue to proceed.
Okay, our panelists here, we have Professor Mao here. Yes, Professor Mao Yokota.
Hello. Maybe we
Yes.
can have some discussion time, I
Yes,
think.
yes. Okay.
Yes,
The
one by
discussion
one.
time will be
Please.
by
Yes,
panelists
nice.
and discussant. Please, anyone want to ask question?
Thank you very much for a nice presentation. So maybe so many the numbers are already you experienced, I think. So one of your maybe indication, I think the very important for treated by endoscope, less the bloody how do I say the intraoperative bleeding is very important factor. I think. Can you tell us how you can what type of the examination before you do the surgery?
Professor Yoko Kato, thank you for your question. Endoscopic keyhole approach actually very new procedure, new concept. So indication is not yet established. But in my opinion, at first to reject the skull-based tumor, at first open microscopic procedure was best as a primary procedure. But if we learn the surgical technique of the microscopic skull-based approach, we can minimize the procedure based on keyhole endoscopic approach. So this is one of the very important message to the young neurosurgeon. Just keyhole endoscopic approach is not good to treat the all kind of the skull-based approach and also the training of the skull-based surgeon. So at first, in my opinion, of course, at first it's better to learn the microscopic skull-based approach and then minimize the procedure based on the same rule. Today I present. It's my comment to this procedure. Thank you, Professor.
Thanks so much. Thanks so much. Amina?
Professor Goto, I have another question. For the keyhole from the frontal here, and then have you ever tried from intraorbital approach for the keyhole?
Yes. Today I save the keyhole transorbital approach, but the transorbital approach also the very nice keyhole approach to some area. For example, if the region located anterior wall, anterior part of the temporal bone, transorbital approach very reasonable procedure. We also published to the paper to neurosurgery. And also, if the tumor located sueno-orbital meningioma, also the endoscopic transorbital approach very useful. So, of course, transorbital also very good procedure.
Which one you preferred use more in your surgery?
Transorbital is and subfrontal approach. Indication is overlapped. So I think that's just surgeon's preference in some case. It's
Okay.
just my impression.
Thank you, Professor Goto. Anyone would like to ask questions? Okay.
Professor Goto, I have a question. Thank you very much for the excellent demonstration. It's very nostalgic. I've had the privilege and opportunity to see you in person several years ago when I was an observer there. Yeah. Thank you very much. My question is, I'm just curious to know if you use any lumbar drain for any of these procedures.
Thank you. Keyhole approach, at first it's a bit difficult to drain the CSF. So in all cases, I prepare the lumbar drain. In all cases. But usually the anterior transpetrosal approach, I use drain the CSF during the surgery. But subfrontal or interhemispheric, usually just prepare the lumbar drain, but not drain the CSF during the surgery.
Hi, Dr. Goto. This is Abhida.
Hi.
So you have used endoscopic endonasal approaches for some of the before, like for anterior cranial fossa meningioma. You were going endoscopic endonasal. Now, will you say you have changed your strategy, or which route do you prefer? Do you prefer keyhole, or do you prefer endoscopic endonasal?
Thank you. I did not change the strategy. Even now I use both technique, keyhole and endoscopic and nasal, based on the location of the tumor. If the attachment or origin of the tumor is pure central skull base, in such situation, the endoscopic and nasal is very reasonable route. But if the tumor located near the anterior clinoid or lateral side of the optic canal, keyhole is more reasonable compared to the endoscopic and nasal. So location of tumor is very important to select our approach.
So
Thank
basically,
you.
those will be lateral to the ICA or to the sixth nerve. You will prefer a keyhole.
Yeah.
And if you do a minimally invasive, like for a trigeminal schwannoma, my craniotomy will probably be so much, but I will still use a microscopic approach. I think you were also using the same earlier. So then, I mean, what advantage does the endoscope give you, except for the, access point of view? Is there any?
Yeah. The size of the skin incision and craniotomy is of course small compared to microscopic subtemporal approach. But I think it's not so different. But of course, more minimum if I use the endoscope. So I know your technique of the subfrontal approach, subtemporal or subfrontal approach. So not so different. But if you use endoscope, you can minimize skin incision and craniotomy more small.
Okay, thank you. That was a wonderful presentation. I really enjoyed.
Goto-sensei, what about the duration of the surgery? Dr. Abhida, she asked the two types. The duration of the surgery is much less with your technique.
In my feeling, the surgical time not so different compared the 𝑦𝒄𝒄 or 𝑬𝙧 technique. I know their technique. I impressed. I'm very influenced Dr. 𝑦𝒄𝒄 or 𝑬𝙧 technique, subfrontal or subtemporal approach. So surgical time not so different in each procedure.
Thank you very much.
Thank you, Professor Goto. Just a follow-up from Abhida's question. Does your decision change? For us, a lot of us, we tend to be more familiar microscopic, but your decision change if the tumor is larger? Do you start off with microscopic and then put in your endoscope towards the end when the tumor is smaller, or go all the way with endoscopic? Does it make a difference? Because if larger tumors, a microscopic will be actually faster initially, and then maybe, so does it make a difference for you?
it's a bit different, difficult question. Size of tumor is one of the factors to decide the approach. But if the size of tumor is large, but attachment of the tumor not large, in such situation, endoscopic approach was enough. But if the tumor not so large, but attachment is very wide, in such situation, some case microscopic approach very reasonable. So there is many factors to decide the surgical approach, the size or hardness of tumor or location of tumor. So sorry, it's very difficult to see ask your comments. But anyway, size is one of the factors to decide the approach. Thank you.
Thank you, Professor Kato.
If I may ask Prof. Goto one thing. Sensei, thank you very much for this wonderful presentation. We learn every time I see you. Just a clarification, there are 3 instruments in the field. Which one are you holding and which one your assistant is holding? There is a suction, there is a mic holder, somebody is holding, and there is a dissector. So which one is the assistant?
When we perform the keyhole endoscopic approach, our assistant, neurosurgeon, hold the endoscope and also use one instrument, suction or forceps. And main doctor use the suction and scissor or suction and forceps. So we can use the 3 instruments.
Thank you very much.
Professor Goto, thank you for your wonderful lectures. So I have one question.
Okay. It's okay.
Especially for, skull-based meningioma, especially for skull-based petroclival region. What kind of tumor do you choose the endoscope? What kind of you said only not size. So what kind of tumor do you choose the open craniotomy?
Usually in case of the petroclival meningioma, I usually use microscopic transcranial approach. Because in case of the petroclival meningioma, we need the meticulous dissection from the cranial nerve. So usually I use microscopic procedure, but today I present one case. The age of the patient is 76. In such situation, we need the total resection of the tumor. They compress the tumor from the brainstem and confirm the pathology is our main goal. To achieve such goal, less invasive procedure very reasonable to the patient. So I decided the keyhole endoscopic approach. But usually I prefer to use a microscopic, the skull-based approach to petroclival meningioma.
Okay. Thank you so much.
Okay. I think we should run to another speaker. The other speaker will be Dr. Sneha Chitra. She's the senior fellow in neurofunctional neurosurgery in Wessex and UK. And the title would be the thalamotomy for movement disorder, the role of listening in the current era. Please, Dr. Sneha Chitra.
Thank you very much for this wonderful opportunity. It's always a pleasure to present in the ACNS webinars under the patronage of Professor Kato. My regards and respect to all the professors here. I would like to share my screen now. If you can, are you able to see my presentation?
Not yet. Please share it. Did you click the share screen button? Yes.
Okay.
Please make it full screen.
All right.
Okay, fine.
Good morning from Southampton, UK. The topic for the day is thalamotomy for movement disorders, role of lesioning in the current era. So the use of thalamotomy has been around since the 1950s, but then why did this procedure go out of vogue? Significant side effects, and everything was related to the targeting errors. So the main target for thalamotomy is the 𝑽M nucleus, and it is not visible in the traditional 1.5 or 3 Tesla MRI. And hence we had to resort to anatomical landmarks or atlases back then in the 1950s. And that could explain the significant adverse effects and complications that was seen in the series back then. And in 2023, that issue is non-relevant. We have the latest MRI sequences, including the diffusion and the DTI, now which are allowing us direct targeting of the 𝑽M and identification of the key tracts such as the 𝑑RTC. And this has been a revelation in the world of lesioning. So as you can see here, we have evolved from bilateral frontal leucotomies to stereotactic lesioning, and to this, which is currently the standard lesioning procedure based on the DTI and the MRI DWI. The lesions are hardly seen on the scan and with excellent results. So what is the main indication is medically refractory tremor, and it's essential tremor and PD-related tremor, and also the dystonic tremor, which is seen in the elderly. So the worldwide prevalence of tremors is 0.9%, and it's markedly increasing with age, with 4.6% incidence in people above 65 years. And we already know how the elderly population is increasing worldwide, and the incidence of tremors is only going to increase. And more importantly, these tremors are refractory to medications, and the medication effect also decreases with time, up to 25 to 50% failure rate with medical treatment alone. And in the elderly population especially, it has significant effect on quality of life. These people struggle to even carry out the day-to-day activities, simple activities such as eating and taking care of themselves or driving around. It makes a huge impact on their life. Although deep brain stimulation is currently the mainstay of treatment, the cons of DBS, it's invasive, it requires a permanent implant and maintenance of the hardware, not to mention the hardware-related malfunctioning issues. And it may not be appropriate for especially the elderly patients who are very frail and have other medical conditions which are contraindications for DBS implantation. So at the Wessex Surgical Movement Disorder Service, we have a pathway in place. A detailed clinical examination and involvement of the movement disorder neurologist is there for the correct patient selection. And once the suitable candidate is selected, there is a detailed recording, and it includes gait, the tremor assessment, and everything is video recorded, including the handwriting. And then finally, with the imaging, the patients are discussed in the MDT, and the patients are selected and put forward for thalamotomy. So this includes you can see that the spiral here and the straight line. Now, this is by a patient who is left-handed primarily, and we can see how significant the tremors are. So these patients are then taken for an MRI head. This MRI is done under GA so that we are not having even the slightest of movement artifact. This is very important to get precision targeting. So the DTI sequences and the DWI sequences are taken in this MRI. Now, these are then fused with the BrainLab Element software, and this has made lesioning so effective and precise because it can give us the segmentation and the DRTC tract precisely and accurately. Enough research has been done to prove its accuracy. So the CT is then fused with this BrainLab software. We identify the tracts, we identify the nucleus, and including the segmentation, we are able to exactly locate the target for lesioning. Now, this is again another image to show how we can and this is the red nucleus, and then how we can actually target the 𝑽M here with the DRTC going right through the 𝑽M there. So we usually place the target in the center of the 𝑽M, sometimes a little caudal to include the caudal zona incerta or the subthalamic region as well. Now, this surgery is a daycare surgery. That's again a boon for the elderly patient, and it's done under local and sedation, which helps us to do extensive on-table testing and make sure there are no side effects, motor, sensory, and speech. So we use the ZD frame, and then it's fixed under local and a bit of sedation, and then they taken for CT, which is again done under sedation to eliminate any motion artifact. The fiducials and the stereotactic coordinates are then obtained. They are then fed to the brain lab software, and we get the actual targets for the fiducials on table. The coordinates are obtained. Now, this is the entire setup. You have the ZD stereotactic system, the phantom, and everything is MER based. So we are recording extensive MER on table. And then the lesioning is with the InnoMed system, the RF lesion generator. So the patient comes back to the operating room with the frame, and then we put in the actual frame. The coordinates are confirmed, reconfirmed. So the targeting has to be accurate. There's absolutely no room for error here. Then the burr hole is placed. At every step, the stereotactic coordinates are checked and rechecked. So the probe is then introduced to the required depth, and the MER electrode inserted, and the MER recordings are started. We get a very classical rain on the tin roof, sound and pattern of the burst tremor pattern on the MER. And then this is correlated clinically. And this time the patient is awake, and we are doing extensive on-table testing, looking for the tremor, asking them to, take water cup to their mouth, draw the spiral, draw a straight line, all the time constantly monitoring to see if they're having any motor twitching or sensory side effects. The speech is also constantly monitored. Now, once everything is under control and we are happy with the site of lesioning, and we're happy with the stimulation as well, stimulation at 2 Hz to look for motor, at 50 Hz for sensory, and then when we achieve the lesioning frequency that's necessary, and there are no side effects, we decide that is where the actual lesion is to be done. So the lesioning, we do again a test lesioning at 44 degrees for 15 seconds and make sure everything is okay, the speech, motor, sensory, and that we have good tremor control. And then a permanent lesion is made at 80 degrees for 90 seconds. Some cases, we make more than 1 lesion. So following successful lesioning, the patient is then returned to the scanning room. Now we take a scan again, and then this is again fused back with the brain lab software, and the actual lesioning is then confirmed to make sure we are on target. The frame is then removed, the patient is taken to recovery and then assessed again. And most of these patients are able to go home the same day tremor-free. It's almost like magic for these patients, and they're so happy. So this is the post-op CT. As you can see that the lesion here is hardly seen. It's a small hypodense area. And with the merging of the software with the DRTC and the WIM nucleus, you can see how exactly we are there. The center of the lesion is where we intended it to be. So the results are excellent. Good tremor control and improvement in quality of life. No major complications, which could be bleeding or other speech-related side effects, dysarthria. Sometimes they can have gait issues, sometimes weakness, but all these gait issues are usually resolving spontaneously within a few months. And when you see the patient in the OPD follow-up at 6 weeks, you can hardly recognize them with the major outcome they've had with the tremor out of their life, and they can do everything, even eating and taking care of themselves, which was very difficult earlier. Now, this is a very recent article, which again emphasizes all that I have said, return of the lesion for localization and therapy. So improved software and improved radiological various sequences, including the DTI, has changed the field of lesioning. We are now able to localize to brain circuits rather than brain regions. And with the advent of connectomes, this is only going to become more exciting in the future. So improved localization means very few errors or no errors at all, and more precise treatment targets. Although there are limitations and caution is warranted, the improvements in lesion-based localization are refining our therapeutic targets, and then it is only providing new ways to create therapeutic lesions which are more safe and effective. Now, this is again another article where they have measured the lesions, and they have actually gone on to confer that the focused and predictable lesions are comparable with the radiological lesioning that was intended and what was achieved after surgery. So RF thalmotomy remains an important therapeutic option owing to its simplicity, effectiveness, wealth of supporting clinical experience, and favorable health economics profile. This is a patient, the same patient who was actually left-handed and underwent thalmotomy. So this is the pre-op video of the patient. You can see the tremors. So the patient is having quite severe rest tremors as well. These tremors are worsened with actions. So most of these patients tend to have bilateral tremors with one side worse than the other. And a pure unilateral tremor is again going to be an ideal candidate for lesioning. So this patient is left-handed and the tremors are more on the left side. He had lesioning for the left tremors. So we all can imagine how badly this is affecting this patient's life. So, and then let me quickly go on to show, this is how they're able to draw the spirals. They're actually unable to draw or even write their name or sign their name. So this is a post-𝙁𝒚otomy picture. You can see how beautiful the spiral is and how straight the lines are. Now, this is the same patient after surgery in the follow-up clinic at 6 weeks. So I'll go on to the area where we're demonstrating the tremor here. So absolutely no tremor on the left side. The tremors are there on the right side. We're now having patients returning to us and asking for the lesioning on the other side. There is now approval to do bilateral lesioning with an interval of at least 6 months in between the two lesions. So the left side is back to as good as normal here. To conclude, radiofrequency lesioning 𝙁𝒚otomy is a safe and effective procedure with excellent results for medically refractory tremors. It's extremely cost-effective, and that's going to be a boon for all the low and middle-income countries when compared with gamma knife and the very exciting EMA-guided focused ultrasound-based lesioning. It's better suited again for the elderly population with significant medical issues where DBS is going to be a complicated procedure. And as I said earlier, precision targeting is now possible and with minimal risks and target errors. In summary, stereotactic lesioning is still relevant and is here to stay in the era of neuromodulation. Thank you very much.
Thank you very much, Dr. Sneha Chitra. It's very wonderful and awesome surgery and wonderful result. I wonder if there's any question from for the speaker, please, from the discussion and panelists. Please, Dr. Mao Yokota.
Thank you for your wonderful presentation. Sorry, I don't have any experience about functional neurosurgeon, but my question is, how long does the effect last? Okay. Sorry, I can't.
Yeah,
Can you unmute your, okay.
Yeah, sorry. I must have clarified the lesioning procedure is a permanent procedure, although we have a small subset of patients who have recurrence of the symptoms, but very mild. Down the years, maybe in 3 or 5 years' time, they start to get slight tremors, but then at that point, there's an option to do lesioning again, or they could be hiked up on medications. So that's why nowadays a lot of people are resorting to 2 or even more lesions and not just stopping with 1. Although if you lesion more, the side effect profile is going to be more. So lesioning is a permanent procedure.
Okay. Thank you.
So another question for from Dr. Ahmad Fawaz Pirsan, please.
Okay, thank you. Thank you very much. Nice presentation and nice achievement. I'm Dr. Pirsan from Afghanistan. Thank you. I'd like to know about the recurrence and if the tremor recurrent do radiofrequency as well or do DBS?
I think I just clarified that in my answer right now. The recurrence rate with a permanent lesioning, especially with 2 lesions that we are doing nowadays in most of the patients, is extremely less. After 5 years, they might have mild tremors, at which point we could again do another lesioning. So considering they're only going to become older 5 years from this point onwards. or best controlled with medicines. Yes, DBS is an option, but then the primary advantage of thalamotomy is we are avoiding any kind of hardware or the need for programming and the cost. So DBS is extremely pricey, with regards to low and middle income countries for tremors. And we are looking at thalamotomy, which can be a single permanent lesioning procedure, like a daycare surgery for the elderly people. So no implants, no concerns about programming. So it is best suited for such population and in such places where we have a resource which are limited.
Thank you.
Any other question?
As maybe the Goto sensei, do you, in your institute, maybe Dr. Uno sensei is doing a functional surgery. Do you have any comment or?
Thank you for nice presentation. Sorry, of course, I'm the skull-based surgeon, so not familiar with functional surgery, but we have the functional team. So our team usually prefer the DBS, or of course some patients treated by the FUS, MR guide FUS. So I'd like to ask how to select the patient. Just
That's a good question. We offer them everything. We tell you have the option of DBS, you have the option of MR-guided focused ultrasound thalamotomy, and you have the option for the lesioning thalamotomy. And the wait list for lesioning thalamotomy is the least, and the wait list for the other cases may be more. And also, when you tell them that you're going to have a hardware, permanent hardware or an implant in your body, which might require several programming sessions. And sometimes most of these patients, the age profile is above 75. We have a lot of people in their 80s. They might have other significant medical conditions wherein a DBS can seem a bit more complicated. It's a longer procedure. The operative time is more. Sometimes it is to be done as a staged surgery. So we give all the options to them. And in our center, we don't have the MR-guided focused ultrasound yet. So we have the option of DBS versus lesioning. And when the patient has significant bilateral tremors, we are in favor of DBS. When both are severe and both are equally severe, and the age group is 60 or on the younger side, we advise for DBS.
Thank you.
Hi, Sneha. Nice to see you.
Same here. Hello.
Sneha, they're doing a lot of detailed connectomic analysis of these tracks. So do we all do this? All that in that zona incerta and that zones of forest. So do you also, and then you select a target?
No, we are not still using the connectome-based approach, but that is currently the research hot trend in functional. But maybe in the future we'll start using that. For now, we are just using the DRTC alone and mapping it and using to target the WIM. So that's why I said we are targeting slightly inferior to the WIM as well, so that the tip lies slightly in the subthalamic region, so that the caudal zeti and the furrow is also getting a bit of lesioning, although that the main is going to be in the center of WIM, because some of these tremors originate from the subthalamic region as well. So using connectomes, and once the brain lab gets the connectome integration in and we have enough software, I think that will be the future in this field.
Thank you. All the best, Sneha.
Thank you.
Thank you very much for a very nice discussion and question. We move to another speaker from China. We have here Dr. Zhixiao Yang. She will present an unordinary text title. It's a gravity surgical technique, gravity-assisted surgical technique. Please.
So, thank you very much. So I will share my screen now. Okay. So can you see my screen? Yeah. So wait a minute. Good evening, professors. I am Yang Zi-xiao from Huashan Hospital, Fudan University. It is my honor to share my topic, gravity-assisted auto-retraction surgical techniques in neurosurgery. It is a teamwork with Professor Song, and also thanks for the guidance from Professor Zhu and Professor Mao. I am now an attending neurosurgeon from Huashan Hospital. My research concentrated on neurosurgical treatment and mechanism study of cerebral vascular disease like aneurysm and cerebral cavernous malformation. The gravity-assisted auto-retraction surgical strategy is very useful for lesion near the falx. For example, the parafalcine meningioma, the cingulate gyrus glioma, and the corpus callosum AVM. For parafalcine meningioma, the covered cerebral cortex at the overlying bridging veins represent the major surgical challenges because of the potential impairment resulting from the excessive brain retraction or surgical manipulation during the operation. Gravity-assisted microsurgery is a promising technique to achieve a no retraction operation and preserve the covered cerebral cortex and bridging veins. Here is a view showing a typical position setup. Assuming a tumor location in the right frontal area, the patient was placed in a supine position. The upper body was elevated 30 to 45 degrees to improve venous drainage. The head was turned 80 to 85 degrees, deviated from the vertical axis, placing the tumor in a lower position. So here, the difference from most operations is the tumor is in a lower position. So the head was also slightly tilted to the contralateral side to place the falx 45 to 60 degrees above the horizontal plane. Using this position, the brain relaxation will be excellent. The gravity will move the apsilateral hemisphere downward even more, so it will give us a space to do the surgery. The gravity-assisted position can be used in different surgeries. So here are some cases. The case one is a video we published on ACTA. Case one is a gravity-assisted endoscopic cingulate gyrus glioma resection. The cingulate gyrus is part of the limbic system with extensive connectivity to different anatomical and functional areas. The traditional transcortical approach for a cingulate gyrus glioma contains high risk of transit or even irreversible post-operative hemiplegia. In the picture, the MRI demonstrated a left cingulate gyrus high-grade glioma. The figure 2 shows the anatomical relationship of the tumor and adjacent eloquent parenchyma. In particular, the SMA and the paracentral lobe on the medial surface of the brain. The key to keep the potential of the motor function recovery is to preserve the paracentral lobe, cortical spinal tracts, and even the SMA. Therefore, we planned the gravity-assisted endoscopic cingulate gyrus glioma resection in this case. The endoscope offers several advantages, including improved up-close inspection, optimal illumination, and the option to use an angled line of sight to work around the corner. After inserting the wide-angle endoscope and localizing the tumor under navigation, a small portion of the thin cingulate gyrus cortex overlapping the tumor was removed, and the tumor was located. The fluid in the cystic portion was released, and the brain got more relaxed. It was important to secure the feathers first, and then further gross debulking could be performed under caution and without hurry. MRI on the post-operative post-operative day 3 demonstrated a gross total resection of the tumor. So here is the second case. The case 2 is a surgical removal of a challenging deep-seated corpus callosum AVM. In this case, a 64-year-old male was admitted to treat a ruptured corpus callosum AVM. In order to facilitate surgical manipulation under the robotic digital microscope, a gravity-assisted supine position was utilized. Intraoperatively, identifying and preserving the transit and bystander artery is important, while skeletonizing the anterior cerebral artery. Using the gravity-assisted auto-retraction surgical technique, we can recognize the ACA and its perforatous arteries to the AVM first and reduce bleeding. The nidus was totally resected and the patient was discharged with a good prognosis. And then it is the third case. It is a gravity-assisted ipsilateral or paramedium approach for parafalcine meningioma resection. This is a case series which was published on What Neurosurgery. In the example, we see that the MRI showed a left frontal parafalx meningioma. Gravity-assisted auto-retraction surgical techniques were used for tumor resection. The surgical position is similar with the tumor on the lower side to the falx. A linear incision was planed anterior to the coronal seizure using a neural navigation. The image on the navigation system showed the shortest surgical trajectory set for this patient and no bridging vein in the surgical corridor. The interhemispheric surgical corridor was automatically opened by gravity-assisted brain retraction, and the tumor base was resected first. So in this gravity-assisted auto-retraction technique, because the falx is above the tumor, so we can resect the meningioma base first. So it helps us to reduce the bleeding. The Simpson grade 1 resection of the tumor was achieved with the affected falx removed. The advantage of these techniques are first is the ipsilateral frontal lobe can be auto-retracted by gravity, so we do not need to retract the lobe. The second is the base, the tumor base can be resected first. So from September 2018 to September 2019, 10 consecutive patients with parafalx meningioma underwent microsurgery using the gravity-assisted ipsilateral paramedium approach was collected and analyzed. The result from the present case series has demonstrated the safety of the gravity-assisted ipsilateral or paramedium approach. This approach provides good tumor exposure and clear identification and preservation of bridging vein, does not result in contralateral brain impingement, and does not require excessive brain retraction. So we further analyzed the 62 consecutive patients with parafalx or parasagittal meningioma surgically treated by gravity-assisted auto-retraction approach. This case series describes gravity-assisted auto-retraction surgical strategy and the favorable patient outcomes demonstrate its efficiency and safety. The surgical strategies were mainly dependent on the group classification by coronal seizure and lambdoid seizure. So here we can see in the figure 1, the meningioma can be divided into 3 groups first. That is the anterior group before the coronal seizure, and the middle group, and the posterior group behind the lambdoid suture. So further, the middle group can be also divided into 2 different groups. That is the pre-Rolando wing and the post-Rolando wing. So so finally, we found that the surgical position was decided by pre or post Rolando wing. So the anterior group and the middle group with pre Rolando wing, the position is the supine or lateral, just like we have described previously, and the posterior group and the middle group with post Rolando wing, that we can use the park bench position, and we use the approach just like the Popin approach. So here are 2 examples. For the anterior group and the middle group before Rolando wing, we use the position mentioned previously. This case is similar to the previous case. The parafelsin tumor is exposed after opening the dura, and the ipsilateral frontal lobe falls with gravity once the cerebral spinal fluid is released. Without the use of additional retraction, the tumor was removed in a piecemeal fashion with the forks of the tumor base resected. So it is the anterior and the middle pre-Rolando wing group. So the second group, for the posterior group and middle group after Rolando wing, we use the Popin approach with the tumor on the lower side. This is a bilateral parietal parafelsin meningioma. The patient underwent tumor resection in the left park bench position using gravity-assisted paramedial left parietal craniotomy. The tumor was removed in a piecemeal fashion with the forks of the tumor base. After resection of the tumor on the ipsilateral side, the forks was cut and the contralateral tumor was exposed. The tumor finally achieved Simpson grade 1 resection with a straight sinus preservation. So this case series described a gravity-assisted auto-retraction surgical strategy for parafox and parasagittal meningioma, and the favorable patient outcome demonstrate its efficiency and safety. So on conclusion, there are several reasons that we recommended the gravity-assisted auto-retraction technique. First, the gravity-assisted microsurgery is a promising technique to achieve a no retraction operation and preserve the covered cerebral cortex and bridging veins. So with no retraction, we can get the space between the lobe and the falx just with the help with the gravity. Second, using this approach, we can first reach and resect the meningioma base in meningioma, and we can also first reach the feeding artery from ACA or its perforators in the case of the AVM and glioma. So we can reduce the intraoperative bleeding and make the operation more safe and effective. So it is a teamwork from Huashan Hospital, and thanks for the guidance of my tutor, Professor Mo, and also thanks for all your attention. Thank you.
Thank you very much for your wonderful presentation. The gravity can help our approach to the tumor very easily without any retraction. Probably there's a question from the panelists and discussion. Professor Kato, maybe?
Maybe Habib?
It's Habib from Uzbekistan. Thank you for your such informative and amazing presentation. We also use a gravity-assisted surgery, but not in endoscopic, just microscopic. And sometimes we choose a surgical corridor based on venous anatomy, like 𝑑𝙧𝒕 vein, projection of 𝑑𝙧𝒕 vein in the 𝑦𝙑𝒃 meningioma. In some cases, selected cases, there are somehow the size of tumor is very large and it's highly vascularized. In this case, I personally prefer to use as a combined approach to see blind zone of endoscope or exoscope. So in your practice, how do you choose a surgical strategy for combined surgery in such a lesion?
Thank you for your question. That we divided the meningiomas into different types based on their classification of location and also based on whether they are small or large. So also there are some bilateral meningiomas that we need to consider especially. So for most meningiomas, we will use this gravity-assisted auto-retraction position. So in this situation, that we will use this approach with the tumor under the 𝑦𝙑𝒃. So in this situation, we can the gravity can help us to separate the tumor and the tumor and the cerebral lobe. So even when the meningioma is very large, it will also can help. But when the meningioma is very large, we will do the intertumor resection to make it easy. Because sometimes just to use the gravity-assisted attraction when the tumor is very large, it's difficult to separate the meningioma and the cerebral lobe. So it depends on the whether it is large or small. And sometimes, for example, the bilateral meningioma, if one side is large and another side is small, that we will locate the large part under the 𝑦𝙑𝒃. So we think that is help us to separate, and also we will resect the meningioma base of the large part first, so that the bleeding can be reduced during the operation, and then we will cut the 𝑦𝙑𝒃 and to do the small part. Most of the time we do not do the bilateral opening of the dura to cut the meningioma, but sometimes if the shape of the meningioma is very special that we cannot cut the 𝑦𝙑𝒃 and to resect the contralateral meningioma, we may do the bilateral incision of the dura. Thank you.
Thank you. One more question. Do you use a preoperative embolization for such kind of giant meningiomas? And what about time between embolization and surgery?
You mean the embolization, the endovascular in our hospital, most meningioma we do not use the embolization, but for the high vascular, but for other tumors like with the high blood flow, that we will do. For example, the for example, for some skull-based tumors like the sorry, wait, yeah, the
𝑎ngioperithoidoma, is it?
yeah. Wait a minute, sorry. Hemangioblastoma, and also some other tumors, but not in the meningioma most of the times, because we think that if we first resect the tumor base, the blood supply will be reduced, and it is safe to cut it, even in large meningiomas.
Okay, thank you for response. It was very interesting to know your experience in gravity-assisted surgery. Thank you very much.
Dr. Sensei, do you do the pre-operative embolization sometimes? Dr. Sensei?
Pardon, I didn't got the point.
Oh, sorry, I asked Dr. Goto Sensei.
Oh, yes.
What is your... Do you do the pre-operative embolization sometimes?
In case of the Hwalsian meningioma?
Yes, big one.
I usually not use pre-operative embolization. But we, of course, some is a surgeon's preference, but I usually use a contralateral approach to use a Hwalsian meningioma. So devascularization is easy to the contralateral side. So I prefer use a contralateral approach to resolve Hwalsian meningioma.
So, Linda?
Is there any other question? If not, I would like to ask question whether do you still use the sitting position to for your surgery, Dr. Yang?
Sitting position is not very useful in our hospital, and because we are afraid of the sinus embolization of air, so it is not very common in our hospital until now. Yeah, but sometimes previously we use it, but it is not used.
Yes, but do you think it is help for the gravity assisted or not?
Pardon, I didn't get the last question.
Yeah, I know that the sitting position, everyone now one by one leave it because there's more an advantage from that. But how about do you think the sitting position for the gravity, is it make something kind of difference or something?
Yeah, we think that the sitting position is very good for to decrease the pressure. So use the sitting position that sometimes in the tentorial meningioma previously, and also to do some surgery to reach like wait a minute. Sometimes we use the sitting position. We use a modified position just like the sitting position to do the exoscope surgery of the pineocytoma. Sometimes we just use the approach under the tentorial, but it is a modified position, not just the sitting position, like a park bench position, but with the head more like a sitting position. But just the sitting position is not used in our hospital now.
Yeah, thank you. And anybody wants to give a comment for that? What about you, Professor Goto? Do you still use the sitting position?
I just comment to the sitting position. In some tumor around the posterior fossa, sitting position is very useful in some case. But to reject the supratentorial region, sitting position is too much. We evacuate the CSL. So during the surgery, we took the sitting position, intracranial pressure becomes very, very low, too much. So, to decrease intracranial pressure, very low is also very risky, cause post-operative bleeding or something. So, it's not good to use the sitting position to operate the supratentorial region. It's a comment to the position. Thank you.
Thank you very much, Professor Goto. Anybody wants to ask more questions?
Yeah, just a comment. I think Xiaoyang, your presentation was very good, especially for everyone who's taking up, do surgeries. I think this is the basic of our neurosurgery. We all know that gravitational is very important. So thank you for presenting this and giving us a look into the cases you have done and the outcomes. Thank you very much.
Okay.
Thank you.
Thank you very much. Wonderful presentation and wonderful discussion we have today. If there's no other question, Professor Kato, please allow me to close this session.
Yes, of course, please.
Thank you very much. Thank you very much for the opportunity from ACNS for me to do the chair for today, ACNS Win webinar.
No. We have two more talks.
Oh, two more.
Yes, two more talks. Yes.
Two more talks?
Yeah.
I'm sorry, it was only three.
No,
right,
two more.
Okay.
𝑦𝙂, you can start.
Sorry, because it's only.
Okay. I'll take over. I think our next talk is by Prof. Yeah, I think maybe the initial flyer sent to you, Myrna, maybe was not complete.
The flyer sent to me. It's only.
It's okay. No worries. Yeah, that's what I was thinking. We're pretty early to finish. Our webinars are usually about 2 hours.
I'm sorry. Okay, the next will be moderated by you because I don't have any other two speaker in my list. Please.
No problem. Okay, so our next speaker will be Prof. Mao Yokota. She's a consultant neurosurgeon, Department of Neurosurgery. Good evening, Prof. Mao Yokota. She's from Aichi Medical University, Japan, and she's. Are you ready to present your topic today?
Oh, really? I don't know. Sorry.
So you are discussing.
Only discussion. So
yeah. So Prof. Kato, we
topic.
only have three speakers today in our list actually. Yeah, you're right, Myrna. Correct.
So sorry.
Yeah, it's only 3. Yes, Prof. Sorry.
Yes.
Yeah, Myrna, you actually sorry. Yeah, I think.
Yeah.
I also don't have any.
I only informed for
was actually our discussants. Yes, correct.
I only informed from.
Yeah. Sorry, yeah. Sorry, don't panic. Okay, anyway, Yokota and Kusumi, maybe you have some questions for 3 of our speakers today. Yes. Would you like to ask any questions? Please do, because you are discussants today. Yokota, anything?
Yeah,
yes,
thank you.
So sorry.
So sorry, I don't know. Last Dr. Yang,
Yes.
Thank you for your wonderful presentation. I think it's good to choose the site based on venous anatomy, and I think endoscope is useful in this case because the visual axis is free in exoscopic surgery. So do you use the exoscope every operation?
Yeah, in our cases, we just use the endoscope, but I think the exoscope is also very useful because it do not take the space. We use the gravity-assisted auto retraction because we need more space. We want more space between the falx and the cerebral lobe, and but sometimes when we use the endoscope will take some space, and it will be more difficult to do the surgery. But because in our operation room, exoscope is not very, we have only 1 to 2 exoscopes, and most of us use the endoscope so to help us. I think exoscope is also very useful, especially in our case 1 and case 2 of the AVM and the cingulate gyrus glamour. I think exoscope can also help.
Thank you.
So, okay, I have one question.
Do you have anything to ask or make any comments?
I also have a question to Dr. Yang. I agree with you for Parkinson meningioma surgery, but for glioma surgery, I'm not glioma surgeon, so I'm not. But for glioma surgery, maybe gravity make navigation lost. So, do you have any instrument or something? Do you have any instrument for navigation correction for intraoperatively or not?
Yeah, that is very perfect question. Yes, you mentioned it because after the craniotomy, the navigation will always change because of the release of the cerebral spinal fluid. So when we use this approach, that the navigation's change is more than the previous approach. So we use the navigation to help us to decide the surgical strategy, like which we can, for example, we can resect the tumor before the tract or after the tract. Which part is the incision of the gyrus. So it helps us to do the preoperative surgical strategy. But during the operation, yes, that is true that the navigation is changed because the gravity assisted. Under the gravity assisted the lobe that we will change their position. Some of our colleagues, they do experiments on the model to help us to find a new navigation in different positions and or after craniotomy, but it is still under study. So thank you for your opinion. Yeah, that is very useful.
Yeah, thank you so much. But you take tumor very nicely. Yeah.
Yeah, thank you.
I have also one question for thalamotomy.
Dr. Sneha?
Maybe, yeah, Dr.
Sneha Sensei.
Yeah, I'm here.
Yeah.
Go on.
For the thalamotomy, maybe I lost. Maybe already you said, but both sides of thalamotomy is available for the patient or not? Both sides. Patient have both sides tremor.
Yeah.
That time
So,
you do
yeah,
both side thalamotomy? Or not?
It's contralateral to the side, which is worst. We always do the side which is worse
First
first.
side.
Yeah, and now there is approval to do lesioning on the other side also, but there should be a minimum 6-month interval to do the other side. So this is primarily to allow for the healing of this first lesion and to reduce the side effects, because with bilateral lesioning, the side effects with speech and gait could be more. So we do the side that is affecting the patient most, and it is usually the dominant side.
Yeah.
So in a right-handed individual, we tend to see the right hand tremors are more. And as I presented, it was a left-hand individual. The left hand was the most bothersome for them. But we leave it to the patient and the clinical presentation. Which side is severe will be done first.
Okay. Thank you so much.
Any more comments or any more questions?
Yes.
Yes,
I,
yes, proceed.
I have some questions to Professor 𝑑𝒂𝒂. Actually, it is not questions. I look at his microsurgical instruments for endoscopic keyhole approach. And during my practice, I tried to find some instruments online by eBay or something like this. And sometimes I got instruments very what I want, but it's different from my order. So if it is possible, maybe you ask some your juniors or someone else to send me instrument specification for keyhole surgery. So I liked it mostly. So I already emailed you. Maybe you will send it. It will be very helpful for me.
Okay. I take the list from the company and I will send the email to you.
Okay. Thank you, Professor.
Dr. Harry, maybe you can invite Dr. Goto Sensei, then maybe that he can bring his own instruments with him. I think it's very shortcut to learn.
Yes, maybe we'll find some candidate for surgery in his expertise, and once I invite him, if he is agree based on his time. Thank you.
Yeah.
Is there any more more comments? We don't have to have questions, comments. Yang, would you like to make any comments? You okay? Prof. Goto, would you like to make any comments?
Okay. Today I listened another 2 lectures. Both 2 lectures is very good, and for me also very educative. So thank you for good lecture.
Thank you very much, Prof. Goto. Sneha, nice to see you. So, I mean, you've come back to present on our webinar. We've missed you from our win for some time.
Yeah, I missed you all too.
Yeah, yes, I'm very, very proud of you. You're doing some good work there. Hopefully, when you come back, you can motivate more of our women neurosurgeons and educate us more. So, would you like to make any comments?
Thank you very much. As always, I'm grateful for this platform, and it's a pleasure and privilege to present with Professor Kato and Professor Goto, with both of whom I've had the honor to work and observe in person. So I think it's a wonderful platform for all the YNS, and I wish and hope a lot of people join us in the future to make it more purposeful. And as you said, yes, more women on board as always, with Professor Kato as the patron. Thank you very much.
Thank you, Sneha.
Thank you.
Prof. Kato, anything you want to say?
Yes, thank you very much for, yes. So very good lectures, 3 lectures, especially the Professor Goto is excellent talk. I think the more and more minimally invasive way, I think this is our future. Maybe Goto Sensei, when is the Congress, minimally invasive Congress, I think 2026 or 25 in Osaka?
2027 maybe, in 3 years after.
Yes. Okay. In Osaka, maybe.
Yeah, Osaka.
So maybe you can invite all the female doctors, please.
Okay.
I mean, maybe you should go there. Okay. After also.
Yes.
So this was wonderful, the webinar. Thank you very much for all. Thank you.
Thank you.
Sharon?
So thank you, everyone, and I'll see you all again next month. Thank you so much, Myrna, for chairing our webinar today, and see you all next month. Okay, then. Bye.
Okay. Bye-bye. Thank you.
Bye.
Thank you.
Rajesh, thank you.
Arigato.
Bye.
Bye.
Thank you.